Bonjour à toutes et à tous. Le débat de cette matinée de l'établissement de soins à la Cité de la Santé. Et la première question qui évidemment se pose, j'ai en passé à une conférence de Michel Foucault en 1974, ça ne rajeunit pas totalement. À quel moment a-t-on commencé à considérer l'hôpital comme un instrument thérapeutique, c'est-à-dire comme un instrument d'intervention dans la maladie, comme un instrument capable par lui-même et par chacun de ses effets
in itself
de
and
soigner
through
un
its
malade?
effects to cure a patient? And the answer is around 1760. Before, hospitals were not considered as treatment places. They had other functions, and I'm sure I can reassure you, I'm not going to go into that, but the care instrument is actually quite recent. And we'll see today that maybe we're coming back to a reopening up to new functions, broader, more interesting than just care in itself. So as we know it, the hospital is probably the place where we crystallize the expression, the debate of ideas, and we oppose them sometimes, but hope we can avoid ideologies and prejudice based on the hospital. I suggest we have a look at three ideas. The first one, hospitals, is it a centripede or a centrifugal area, so attracting in itself or pushing out patients? Then second theme is a health city, should it be a public or a private player? And the third one, the third opposition is the future of the city. Is it cure or care? And I really hope we go beyond those simple oppositions, and maybe we can come back to a number of examples, because I'm lucky enough to have amongst my guests many very interesting experience and examples. The first one, which is a centripede or centrifugal, with my first question to Jean-Yves Le QUELLEC. How do you avoid long hospitalization, which might be useless? How do you ensure that patients who shouldn't come to the hospital don't come to the hospital? Well, why do we want to avoid them? Well, because you have constant tension. I'm not going to tell you about, the ER overflowing, people that are looked after where we can and not where we should. A bed is expensive to put in place, to maintain. In terms of staff, it's costly, and it's better to reserve it to patients who really need to be hospitalized. So how do we reach this result? Well, it's difficult, and it means you have to project outside of the hospital. Paradoxically, if you want to avoid for patients to come, then we have to go to them, and that means mobile teams. We have mobile teams for geriatrics, in palliative care as well. We also have hotlines, which means that the hospitals where you have people who may come and use up beds, which are often elderly people or disabled people, then we have support, constant support, so that they are only brought to hospital when necessary. And these mobile teams is, nevertheless, the hospital going out there. And I think that's very important. Maybe just one word so that everybody understands. You are in a very specific territory. You are based in Salon-De-Provence, which is basically the north of the Étang de Berre and the Bouches-du-Rhône, which is sort of north of Marseille. Berre, Miramas, and we stop at Arles. So we are between Aix-en-Provence and Arles. If you go on holiday in this region, you might know. I'm going to give the floor now to Florence Herry, who has a different way of projecting resources straight to the patients, and she has a B2B model. Maybe she can explain what liberal means in this sense. Hello everyone, I'm a nurse by training. I worked at public and private hospitals and also in people's homes, and I agree with Mr. Lequinec. Hospitalization is an event in a care pathway, but going back home is very important to avoid going back to hospital, and for that, healthcare professionals, physiotherapists and nurses have to be able to look after patients properly. The LIBHEROS project is to mobilize healthcare professionals at home, everywhere in France, and also in companies for prevention and for care. And the idea is to give value to those healthcare professionals in post-care, post-hospitalization care, for follow-up care with the technology that is developing with remote remote care as well, so that all city healthcare professionals can work. Can I turn to the public as well? Can I turn to the room? What does the public do based on these kind of problems? Sorry, what does the public sector do? I know this debate with the hospital-centric debate. I think we're beyond that and have been for a while now. I think you gave me some examples, and it would be good to give them again. Yes, these examples are anterior to COVID, which probably helped to decompartmentalize a bit more, but hospitals have some clinics in some places out there. We have mental health care, for instance, that is not necessarily in hospitals, and it's continuing its development through national efforts. In a hospital today, whether it's a university hospital or other, mental health is done more and more in clinics in town, with mobile teams as well, with hotlines. We have suicide prevention units as well, which have changed the offer out there. We could talk about CGID as well, vaccination centres, sexual health centres, women's centres as well, which are opening up. We also have care in prisons and post-imprisonment. And these are actions that the public hospital provides with other players, and it shows that we are opening up very broadly outside of our walls. The other thing was to avoid for patients to come in to be brought to hospital, but you also want to avoid for them to come to A&E services or ER services. And Pradip put in place a crazy project in its ambition, but it's his project, and maybe you can tell us about that. What kind of health center you created for Belfort? Yeah, when you said you have to avoid for people to come to A&E needlessly, we know that 80% are non-vital, but I think it should be for vital cases. And for non-vital, it can be looked after in town. So there is a health center in Belfort. Belfort is a medical desert, and there's 50 specialists for medicine, and there's surgeons, and 8 GPs, and 18 paramedical staff. And we also have another center for non-program care with emergency doctors. It's going to open soon. And we also have imaging with a normal X-ray, a scanner. And we also have a sleep center. I think with these kind of structures, we can look after non-vital A&E, because we have the lab, we have the emergency doctors, we have imaging, so we can do all non-vital of private or public hospitals, and they can come to these centers without being hospitalized after, and I think it's important to do that. And I have the experience of public hospital. I spent 13 years in a public hospital. I also have, I work 3 days for cardiology at the Mulhouse clinic for cardiology. And then there's this health center. It's not quite a village, but we have all the health players, all healthcare professionals who can look after most patients who come to the hospital and to A&E. Maybe just to give you a quick overview of figures, I think there's 1,200 car parking spaces. It's not very fashionable anymore, but in these kind of areas, it means that you have greater accessibility. You have 75 healthcare professionals in that center, thousands of square meters. So it's not just a small center hidden away in an area that nobody would know. No, we have 350,000 inhabitants in Franche-Comté. There's 2 centres only. There's the public hospital in Trévenans between Montbéliard and Belfort, and then there's a small clinic that doesn't have everything in Belfort. So we're quite poor in terms of hospitals and clinics. And with my experience in hospitals, I realized we were lacking people, doctors and hospitals. As a cardiologist, I realized I couldn't open a clinic, but having a health center was a bit easier, and so this is what I put in place. Obviously with aids from the town hall to have a good price for the building and for the center. So we have 1,200 spaces for car parking, and we also have room for other buildings. So currently we have 4,000 square meters. We have over 2,000 square meters that is going to be built as well, and so we'll have 3 buildings altogether. Lamine, what does that mean to you? How in the Federation of Private Hospitals, how do you take this into account? Well, towards the hospital or out of the hospital, I think both are important. We need 2 systems. There are pathologies that can be looked after elsewhere, and it's true that we are lacking doctors. What I see today is that nobody is happy. There's never been so many billions given to health, billions, and we've never had so much. Maybe we have to just consider things, look at all the money that's available for digital, for building, for innovation, for investment. It makes you go crazy. I mean, I've been working in healthcare for 30 years. We've never seen that before. So let's just think about it. Let's just say, okay, what do I do? What do you do? Doctors are not happy. That is true. We have tension in hospitals. Nurses have had pay increases, but they are not happy. And then you have the patients in the middle. You have to listen to patients. You have to say, okay, this is your care pathway. They want to access quality healthcare, and that's the basis. And who provides the quality? Well, it's doctors, healthcare professionals. We are here to organize. And what I've seen during the crisis is that hospitals, which is represented here, and private hospitals too, they have the same missions. We are all in it together. So into the hospital, out of the hospital, it's both, depending on the territory. Yours is a rural territory where you have needs. It was no man's land. There was nothing. And you're here. That's good. There are areas where we are saturated. We can't reinvest in city doctors. We can't have nights and weekends anymore. So emergency care has to be done in a concentrated fashion on the territories. And our patients or clients, our customers, for me, a patient is a cured customer. They have to accept to drive for 1 hour. Sometimes you go around France if there's no vital emergency. I mean, vital emergency is not every day either. So you need both, and you have to bring back trust between healthcare professionals, directors, and give some visibility visibility to the patient. But we need to take time. We've been in a crisis for 600 days. We are all happy to meet. We'll probably go back to our bad habits very quickly. That's us. We'll start saying that public hospitals has everything, private has nothing. Jean-Yves, we'll have to stop that. We have to change. And these 600 days of darkness have to serve a purpose. Otherwise, it's going to lead us to despair, and we're not despair. We also have an architect, GRANDPERRET, here. Do you have some solutions when it comes to urbanism, but also architecture? We saw that sometimes you had some very ambitious projects, and there were some architects who didn't. I mean, there have been some developments before. What does that inspire you? Well, firstly, I'm very pleased to be here because it's true that as a health architect, we work with medical executives, private or public, and I think the role of the architect is important on the health of tomorrow. So whether it's centripede or centrifugal, well, it depends on the site, and this is where we start, the environment of the project. Relationships are not the same. If you work in an urban center, you have a restricted amount of room, and so the building will open up onto the city. We'll have links with associations, with multi-generations as well. So these are programs that you can have on urban sites. And we also work in rural or peri-urban areas. And we feel that services come to them rather than the other way around in that case. So these are variations that we see depending on the site and the environment where you see the building. There is a will of shooting out, also to fight isolation. This is why we have new programs and we have new services to offer more attractiveness, more comfort, and to pool everything as well, to have architectural quality, functional quality as well. Right, I think that we saw this false opposition, as I warned you, between centripede and centrifuge. Yes, you have to shoot out, you have to attract talent, but also patients. You want to avoid having to go too far.
Comme l'a montré Pradip. Si on passe maintenant à ces coopérations qui vont être nécessitées ou qui sont déjà nécessitées
collaborations that are necessary through new situations and not just due to COVID.
Lamine GHARBI, qu'est-ce que vous avez, j'allais dire, en réserve en termes de coopération
do you have under your sleeve in terms of collaboration to avoid for these sites, yours or others, to be completely self-centered, or to have this temptation to be completely self-centered? It's not just public or private, it's public and private and public. It's both. And this is also the way that our missions are evolving. We are evolving into companies with a mission, and we have to strive towards that. We have to go where we're not expected, where the general public, where public hospitals have played their role with a mission. I think we have to play with elected representatives and ARS as well, the regional health authorities. It's easy to criticize them once the game is over, but elected representatives have proved during the crisis that they need to be more present. When you have 13 or 14 departments in New Aquitaine, we have the director in this room, Benoît, but he's got 13 departments to manage. He can't know what's happening on all, so territorial delegations have to be strengthened, and you need to have a boss at departmental level. Because when you have an idea, and we have lots of ideas on all sectors, because we feel that we have more ideas in the private sector, which is wrong. In public, it takes 10 years to get an idea to go through. For us, it can go a lot faster, but it's true that sometimes we get a lot of no's. So the territorial authorities have to answer quickly. If we want to open a day center, we can't wait for the next budget. It has to be a lot faster because patients want a fast answer. This is the digital age. We see things happening quickly, and we're still thinking about 5-year plans, and we have to change this. We have to go much faster, leave players in the field to organize themselves with the elected representatives and users' representatives. But the end decision, the final decision, and here it has to come back to healthcare professionals, that we are, either administrative or doctors.
I don't think one should take precedence over the other. Marie-Noëlle, tell us what you've done, what you've set up with the COVID at the time of the COVID crisis, the cooperation with private sector. You mentioned radiologists who do a number of things, GPs. CPTS, do you have any salient points? Well, I believe that we have somewhat forgotten the territorial hospital groups. Yes, they used to be fashionable. Well, they were set up in 2016. It's not a fad. But they do work. And it's not only public hospitals working with public hospital, even though it's a very important network, but where I work, for example, in Indre-et-Loire, it means cooperations which were strengthened when these GHTs were set up between the public and private sectors, with liberal practitioners, and there's new links, and now the surgeons from the university hospital go and intervene in a private clinic. And then after GHTs were set up, there was COVID, and the cooperations that were being set up between hospitals and social medical establishments, elected authorities, HAD, SIADs, clinics. And with COVID,
sont tombés très vite. Les CPTS sont des éléments très facilitants parce qu'effectivement pour les médecins de ville se
professional health community of professionals has been developed, and they work in one voice. As the minister said yesterday, let's keep the best from all this. So we have to work step by step. In my territory, there is a representative of each CPTS. In the hospital medical boards, we are building all this up. You also mentioned a notion which I felt was interesting, which is an interplace to enable cooperations. Could you tell us a bit more about that? Well, we might go back to this, possibly, but we're presently trying to set up, with the lessons drawn from COVID, we're trying to set up a place of prevention of public health outside hospitals, in collaboration with users, territorial collectivities, picking up the missions I mentioned earlier on. and grouping them, sexual health, vaccination, women's maternal health, etc. All the therapeutical things that can be done outside the hospital. The patients do not necessarily want to go to a hospital for therapeutical education. So we're presently thinking about all that. With the city, patients, associations. So it's what I would call
l'architecte est sensible à ce mot ou cette notion d'intérieur.
interplace. Maud Grandperret, as an architect, are you sensitive to this notion of place, common place, which would ally the associations, private, liberal sectors, all the potential modalities? It's true that over the past few years we've been working on groups of clinics and hospitals, for example, is the Clinique Saint-Jean-l'Hermitage, which is a private, was married to a hospital. So we were lucky enough to work with mixed actors, mixed stakeholders. It's not always easy, but we managed to put everything around the table and sit everything together. And it's very interesting. And for me, I can work with other architectural agencies and where we can ally the private and public aspects. We are presently working on groups of civil and military establishments in Talence, close to Bordeaux. We're working on the Protestant health house of Bagatelle, which will be associated with the health hospital of the army. So different actors, different stakeholders, different ways of working, and it's rather interesting because we try to get everybody to work together, despite the fact that the operations, the modes of operation are different, and we always find modus operandi, and everybody has to find their own place and way of operating so that we do not create an imbalance. But the fact that they're working collectively means that the final project is strong, and the idea is to offer to supply the most complete and attractive offer of care. What about this notion of proximity, which is more ubiquitous than in the past? Because in the past it meant being close, while now it's gradual. It depends on the type of care you need. How does this change the way you advise your clients? Well, we work at different scales. We also associate the qualities of space and reception. We try to organize the areas around the various pathologies and the graduation of care, working on flows. We know that now the health architecture is a very complex thing because of flows, patients, logistics, caregivers have to work together, but they don't follow the same paths and not with the same time frame. And then you have the COVID crisis, which has been reshuffling all the elements, and it's one of the positive elements of this crisis in terms of architectural concept design. We're changing things, forgetting the automatisms that we had up till now, trying to reorganize the units, differentiated in and out flows, and working with the caregivers to adapt the places and the architecture of the various projects. Florence Herry. LIBHEROS has a model which forces you to cooperate with numerous stakeholders, obviously care establishments, companies, pharmaceutical laboratories. How did you end up managing these cooperations? Well, it's true that if we look at the notion of territory, health is not only an issue of public and private hospitals, it's also companies, prevention vectors for breast cancer. I can see that Marie-Noëlle is wearing the pink ribbon. We've seen a lot for COVID. We've seen vaccination and testing being done in companies. They're not health establishments, but they are places of prevention. You also have young companies operating everywhere in France as liberals, and you have the health professionals, and all these stakeholders are working together to carry out missions of prevention and public health. And if we get back to the cooperation between all these stakeholders, there's a main element for us. We work with the public hospitals in Paris to help them organize care at home. And it's something that we introduced when hospitals could not take care of everything. So it's still a tendering process for this home-based care, but you have a lot of people working with hospitals, caregivers, people working with architects, and a lot of other people. Obviously, the pharmaceutical laboratories have their position to play, to occupy in this area, whether it be to bring care at home or in pharmacies or whatever. But cooperation is of the essence. Well, there's the word cooperation, but there's another word which is coordination. You're hoping to have a role in the coordination area, knowing that everybody wants to coordinate. As soon as you ask, everybody says, well, okay, that they have to be the coordinators and that they have all the diplomas necessary to be legitimate. You must have them. You're a nurse by training. What do you want? What role do you want to play as LIBHEROS? Well, I'm a health professional, and I created a company to enable home-based care and other preventative actions. We can't be the sole coordinator for all the care. It's impossible. I believe that coordination takes place at several places during the care trajectory. It can be in hospital, before hospital, after hospital. It cannot be only public or only private, but it has a cost. This coordination is a major challenge, and there's a lot of work being done on that. Jean-Yves, your reaction. Well, we haven't talked about that, but there are territorial support platforms that are going to create a system to support coordination. It's not that we haven't got enough people to coordinate, it means we have too many. For elderly people, we have what was called cliques, mayas, whatever. Even as an expert, you don't know them all. And the idea is to bring them together in the territorial support platforms, which represent a strong link between hospitals and liberal professions, which are a bit forgotten. Yes, they're not very well known, even though each one of you mentioned them during the preparation. But what do you think about the technology element? Because last night, Esther Duflo was saying it's not only an issue of having having the latest technology, but the idea is to have something that we know works and make sure that things happen. And we'll come back to that because this will probably be the link with this notion of capacities and capabilities. How do you look at things? How do you envisage things? A lot of technology, many people, a mix of both. Well, a mix of both. You need technology and you need resource people, resource persons, because if you have a great technology for communication but no one to operate it, it won't work. So you must have available resources on a territory. We talked about disabled people. A number of health professionals are ready to take care of them, but we're faced with families that don't know where to go. So the idea of giving them a hotline is interesting, but this hotline would be of no use if it didn't have an operational directory of resources that we have for all these regions. So resources meaning available beds, public and private equipment with a clear description of resources, capacities, and this has to be extended to the liberal practice, nurses, everybody has different competencies, and the idea is to help. So the idea is to know the territory, and that's a major topic because it has to be constantly updated, and the technical means to operate all this. So I guess that the fact that you can activate the same network for all professionals is something that you, Pradip, put at the heart of your project. Well, when you talk about medical demography and desertification, sometimes you have to work together, the public and the private sectors. In our region, the hospital has 4 radiologists. There are 8 in town and 3 MRI machines in the hospitals, 1 in the city. So if you have 14 radiologists, you have to optimize the means, human means, for the benefit of the patients. So the 2 groups of radiologists in the past didn't speak to each other, but now I was being able to group them, and the scanners, CT scans. I'm going to put in our health establishment, and there will be 1 in the hospital. The hospital always wins, you know. You have to say it. The hospital always wins when you have. But the hospital cannot work without the radiologists from the city, and so I reviewed the file, and there will be 2 CT scans, 1 for the hospital, 1 for the private sector. And it's not a private clinic, but it's a health establishment. And there's also the what is called the médecine polyvalente. In our region, we do not have any beds for that. And you can create beds, but some people can create beds but have no doctors, and we have the doctors and not the beds. So we have to get together to organize things. Yes. You can go, we can manage beds for the hospital. Marie-Noëlle, I don't know what you think about that. Are you ready to open the university hospital in Tours for professionals of the health establishment of Pradip? It's a bit far away, but to come and manage beds, do you lack professionals? Well, we already have people from outside the hospital who come and manage not necessarily beds, but technical plateaus. because you can't have a huge number. So as it's a university hospital, we do encourage mixed practice with the town. It's starting with training because the interns do travel around the public and private sector, so do assistants, and we do see that when people start practice, at least for some specialties, the fact that they can come and use the hospital technology is an asset. Yes, attractiveness.
Now moving to the last theme.
De la santé, est-ce que c'est plutôt concentré encore sur le cure, donc le fait de guérir finalement, ou sur le care,
or is it concentrating on caring, which obviously doesn't mean that you don't cure, if possible, but with chronic diseases, we know it, we are going to live longer with a pathology, sometimes an invisible one, sometimes little known by patients, or sometimes very well known with expert patients, these new types of patients.
Est-ce que Florence Herry, vous avez déjà choisi votre camp?
Have you chosen which side you're on between cure and care? And if so, in which way? This is a big question, but coming back to this topic of health city or health center, if you think about the city or the home, if we look after patients at home, there is obviously both notions of cure and care, caring, but obviously promoting health. When you talk to a patient, you obviously talk about this and that, and this and that is their environment, the healthiness of their home, whether they've got food in their fridge. You know, all this is to do with health, so these are not opposed. But coming back to this topic of medical deserts, even though we're not supposed to, the remote medicine tools with remote consultation, teleconsultation is a way of having access to cure and care by moving a healthcare professional to the home of a patient. I think last year the health minister, Olivier Véran, said that his grandmother benefited from remote physiotherapy treatment, and decrees today mean that you can have a proper payment for these acts. And before it was done as by volunteers, but now it's something that professionals can be paid for, which is even better. And today, the state is going to put in place the digital space for health. And so it will mean that patients can have easier access to these tools. Marie-Noëlle, coming back to you, you also talked about other topics. How can we care, not just the treatment itself, but the environment. This is the Maggie centers for cancer in Britain. But how do you try to push for this type of logic in your region around the University Hospital of Tours? When if we talk about chronic diseases, or if you talk about unequal access to care and people who are forgotten by society, especially, or people in good health that you need to go towards. We talked about a lot about prevention. So all players obviously act on prevention, but you also need to bring information to society on nutrition, on obesity, on sports, and so on. So there are lots of functions, but I think the Maggie centers are good examples of a center. Generally, they are nice places built by renowned architects for patients with cancer who live with a cancer. We don't talk to them just about the disease. There are a lot of things to do with their well-being as well. And it also welcomes the family helpers is not focusing solely on the patient or on the disease of the patient. Quite, we talk about getting back to job, we talk to employers. So these Maggie centers are good ideas, are good examples of global centers in providing care for the patients. This is what we try to do with the model that I was talking about, the CAP Santé in the Indre-et-Loire department, again for social issues mostly. And so we go this way, not alone, we are accompanied, and we have patients' associations that are going to be part of the project. And obviously this is a university hospital, so I must tell you about university hospitals, and research and teaching are going to benefit from these structures. It starts young because the newcomers in the health services will come and work in these centers, and little by little we will have more jobs, and it will also be a place for research. So how does the architect see this place, these structures going back to a protecting center in this way? Have you had projects for these kind of structures or modules maybe within big projects? We generally work on units, so on human scales. So it's true that this is the kind of work that we produce and have been producing for a number of years now. It's based on comfort and well-being. We had this less before, but we try to erase the sort of the white scrubs feeling, to be a bit more reassuring. So we have better treatment of interior decoration, for instance, especially interior design. In Nordic countries, they've been doing that very well for a number of years. It's often very simple, but you create an atmosphere which is reassuring. We also work on the acoustic comfort, the choice of furniture, so that the space is experienced as, as if you were at home, that is reassuring and protecting. And obviously you have colors, material that have to be chosen carefully to bring this back to human scale, intimate, and it's also very important for curing people. During a trip that some colleagues here took to California, we saw in some hospitals that you sometimes have the luxury to treat the ceilings of corridors going to the operating theatre. And it's the ceiling because often the patient is wheeled in, so they look at the ceiling and they keep this memory of the ceiling. So they actually put something on the ceiling or decorate the ceilings. Yes, and it's the same for pediatric units or for imaging units, so that MRIs are a bit less anxious. Quite. We were talking about health city, health centers. Some of you were talking about health villages. At first I didn't quite understand. A city meant democracy, Athenian city and so on. A village is more like a tribe or Gaulish village. So maybe you have a better metaphor than my Gaulish
Tout le monde a ses représentations. Moi, la cité, je pense à la cité de Carcassonne, qui n'est pas l'image la plus ouverte qu'on peut avoir.
Is probably the city of Carcassonne, which is not very opened up.
Par contre, le village, c'est quelque chose de rassurant.
Is reassuring, is a smaller scale, is pleasing, so that's my image anyway. The concept of health village that we have came from one idea. We had to rebuild the hospital and the clinic, by the way, they're both aging. And instead of having a old-fashioned public-private center, there was no opposition, but it wasn't the request. The request was the minister's. And in his answer to the question of the MP, he said there would be a new hospital in Salon-De-Provence if it corresponds to the health objective 2022. It sounded a little bit cryptic, but anyway, we thought about it a lot, and we thought we're not going to go alone. There are a number of health players that have the same problems as we have, and they'll come with us. And they will not just be care providers, they will be health providers. And around that village, the village and the clinic,
mais aussi il y aura un hôtel hospitalier,
there will be a hotel for the hospital, which means we will be able to have interns and residents. Today, well, they are very demanding, we know that, but they have good reasons to be, and they have a choice. They have more offers than we have interns, so they choose where they're looked after properly. So that hotel will be a hotel also for families and for interns that will be welcomed in attractive conditions, not luxurious but attractive. And it's not just the interns for the hospital, but those in GPs as well. And if they are happy in the town and in the territory, there's a chance that they'll settle there. We have a dialysis center as well, and we would like to add some equipment. We have a consumers center, so that they would have an area for all the care providers around them. And then, as you said, Florence,
un équipement qui permette de faire de la télémédecine, de la téléconsultation, de la téléexpertise en lien avec les centres de référence du territoire,
in link with the reference centers of the territory. We have a big clinic, we have a university hospital as well in the region. And then we want to also do remote teaching, which is very important to have a better cohesion of all the community of professionals, to have access to all the resources, and we don't have to then move them to the territory. We can then teach remotely, and it means that we will have access to all structures throughout France. And I must say that the community of professionals in Salon was very interested, not just doctors, but even nurses. They were very interested in this communication and knowledge instrument. So if we manage to integrate all these targets, we have a very broad ambition.
C'est quand même de pouvoir avoir à la fois une réunion, pas de tout cœur de soins, il y aura besoin ailleurs dans Salon, mais ce village qui sera pour un lieu très communautaire pour les professionnels avec des services, il y a un aspect QVT dans cet aspect, pour nous, pour tous les salariés qui sont sur le site, mais aussi les libéraux, une salle de sport, ce genre de choses, donc on y a aussi réfléchi.
Je suis désolé de vous interrompre, mais le temps passe à toute vitesse et il faut qu'on passe à la conclusion. Je pense que Pradip a une conclusion sur les modalités d'extension de son projet. Il a parlé tout à l'heure de Montbéliard, mais je pense que vous voulez aller encore plus loin.
Pour le village de santé, moi je pense qu'il a présenté c'est une ville de santé. Moi j'ai présenté un village de santé à le village de Montbéliard.
Village, well, yours is a city, but mine is really a village. It's much smaller. It looks after the well-being. There'll be meditation, there'll be sports. So it will be a real village within the town of Montbéliard. And I think in each town you need some health centers for GPs, for paramedicals, for a health center, a sleep center for the general public, because they will get good care that people don't necessarily find in a hospital. They want something closer to them, and they want a warm welcome that you don't find in hospitals. In link with the local associations as well, which is your case. Yes, and we're not very helped. The ARS, the city don't have the capacity to aid. They would for the health center with one nurse and two doctors, but not for a health village. We really have to wrap up. I'm really sorry. So I must go to Florence now. One word to conclude. Well, as you said, Pradip, I think healthcare professionals have to be part of the project, whatever the project, in cities and in hospitals.
Ça me fait penser un peu à la cité de la peur.
This scares me a little bit. It sounds like a scary city, but anyway,
j'aimerais qu'on transcende les statuts et
I want
qu'on
to
puisse d'un
transcend
secteur
all
à
these
l'autre,
statuses,
que les
and
médecins
I
puissent
think
passer d'un secteur à l'autre,
it should be possible for doctors to go from one sector to the other, and we should discuss things more. And we must remember the best from those 600 days of crisis, everything but the COVID.
On va travailler toute la nuit, on va reprendre dans l'hôpital public,
we
il va
are
s'occuper des
going
médecins,
to
je vais m'occuper de
I'm going to
l'administration, de
look
la
after the admin, planification and organization. He'll look after the doctors, and we'll try and show you that PDP works.
Marie-Noëlle, votre nouveau
Marie-Noëlle,
patron
your new boss is over
Bien
there.
fait de venir.
Well, that's a good thing I came.
Un mot de conclusion?
Un
One
mot
word
de
to
conclusion,
conclude.
toutes ces idées, elles sont
Well, all
formidables,
these
elles sont portées
ideas are
par des
great. They're
initiatives
carried
et
by
des
initiatives
volontés
and
locales. On
local
parle de
will.
la cité, du
We
village,
talk
du
about
territoire.
city, village, territories.
Il faut qu'on arrive à pousser plus loin l'exercice du financement de ces modèles.
Go into funding those models. Financing these models is really just beginning. It's extremely difficult. It's always difficult when you have coordination platforms, so we have to make headway. So finances, funding this, I understand. And more, just one final word. I think beyond rationalization,
Je pense qu'il ne faut pas oublier le confort de l'usager.
you mustn't forget the comfort of users, whether they are healthcare professionals or patients. So I think that's what's essential for me. Well, thank you very much. Just one last sentence, and I promise Guy that we will not go over by more than 30 seconds. Cynthia Fleury in care is humanist. Care doesn't belong to a class of healthcare professional. Care is something that is shared, and I think this is what we showed today. Thank you very much.